Mm. So our topic this afternoon is about signs and symptoms of psychiatric disorder. Mm. For the signs and symptoms of psychiatric disorders, so we have also to check on the one example is the psychosis, no, for psychiatric disorder. So you understand already what is psychosis, no? So there are three dimensions disturbances in three dimensions when one is having a psychotic disorder, or we term it as a person with psychosis, okay, as part of the psychiatric disorder. So there are three dimensions: the behavior, the affect, and the cognitions. So we'll be discussing each of this. Okay. So for psychiatric disorder, to know the signs and symptoms, so we need to do the history and also the mental status examination. So I think some lecturers already discussed about the mental status examinations. So what is all about mental status examinations, no? It explores or the area of mental functioning and denotes the evidence of signs and symptoms of mental illnesses. Data are gathered for the mental status exam throughout the interview by the initial moments of interaction, including that what the patient is wearing and their general presentations. So by doing the mental status examinations, you will also check the evidence of signs and symptoms of mental illness. So these are the data are gathered throughout the interview. No, one we have for the mental status exam, the appearance and the behavior. So it consists of the general descriptions of how the patient looks and acts during the interview. Okay, so even also in the appearance, you will also know if the person is at par with his or her age. No, the next is motor activity, may be described as normal or slow, that is bradykinesia, or agitated, that is hyperkinesia. This can also give clues to diagnosis, like depressions versus mania. So like for in the depression, it's typical for a depressed patient have a slow, or, but we have also agitated depressions. For mania, they are hyperactive. Okay, they're energetic, no? And we have also a confounding neurological and medical issues. So we have also the the speech, no? Speech is an important part. Okay, the elements you considered include the fluency, the amount, the rate, the tone, and the volume. So it's common, like in the speech for psychotic patients, uh, and also like in depression, they have the rate. It's very slow. The tone is low, and the amount is not as productive, and the volume also is very low. Unlike in the mania, they are more the amount, the rate, the tone. They are more productive. They are more talkative. They are more rate is fast. The tone is high, and the volume is also it's high. And the next one is the mood. The mood and the affect vary in their definitions. Okay. So the mood has two elements. The emotional expressions. Mood is defined the patient's internal and sustained emotional state. Okay. So mood is more subjective. Like you ask the patient, how do you feel? The patient will tell you, I'm sad, I'm depressed. So that's the mood of the patient. What about the affect? It differs from the mood. That is an expression of mood or what the patient's mood appears to be to the clinicians. So it's often described with the following elements. The mood is objective, is what the clinicians or the observe, to the patient. So it has an elements of what's the quality, the quantity, the range, the appropriateness, and also the congruence. We have here also the thought content. Okay. So the thought content, it this is inferred by what the patient spontaneously expresses, as well as responses to specific questions. Some patients may perseverate or ruminate on specific content or thoughts. Okay. While the thought process differs from thought content in that it does not describe what the person is thinking, but rather how the thoughts are formulated, organized, and expressed. The patient can have normal thought process with significantly delusional thought content. Conversely, there may be generally normal thought content but significantly impaired thought process. So these are the examples of the thought process: flight of ideas, blocking, clang associations, and neologism. We will be discussing each of this later. Example of thought content: the delusions, the obsessions, the compulsions. That's the thought content. So these are the formal thought disorders. One is circumstantiality. Okay. It's an over-inclusion of trivial or irrelevant details that impede the sense of getting to the point. So meaning when you ask the patient, if the patient is circumstantial, you will have a lot of details or a lot of thoughts, but finally can answer the questions. While the clang associations, the sounds of the words rather than by their meaning, example, through rhyming or assonance. So there will be rhyming of words. Derailment, breakdown in both the logical connections between the ideas and the overall sense of goal-directedness. The words make sentences, but the sentences don't make sense. So, meaning in the derailment, there would be an illogical thinking, words are not connected, and they don't make any sense. Next is a flight of ideas. Succession of multiple associations so that thought seems to be abruptly from idea to idea. So the flight of ideas, you could understand, but it's jumping from one topic to another. Neologism is the invention of words or phrases or the use of conventional words in idiosyncratic ways. So inventions of new words or phrases. Perseverations, repetitions, out of context of the words, phrases, or ideas. Tangentiality, in response to question, the patient gives a reply that is appropriate to the general topic without actually answering the question. So, patients giving, when you ask the patient is trying to give almost correct, but finally they could not answer the questions. Next is a thought blocking. There will be a sudden disruptions of thought or a break in the flow of the ideas. And we have also the perceptual disturbances. Okay, we have here the hallucinations, the illusions, depersonalizations, and derealizations. Hallucinations are perceptions in the absence of stimuli to account for them. So there would be auditory hallucinations, there will be visual, tactile, olfactory, gustatory. And the non-auditory hallucinations are often clues that there is neurological, medical, or substance withdrawal rather than a primary psychiatric issue. Okay. So illusions, the interviewer should make a distinction between the true hallucinations and the misperceptions of stimuli, the illusions. Hearing the wind rustle through the trees outside one's bedroom and thinking the name is being called is an illusion. So that's an example of illusion. Next, we have depersonalization. Is the feeling that one is not oneself or that something has changed. Okay. And the realization is a feeling that one's environment has changed in some strange way that is difficult to describe. And we have also the abstract reasoning, is the ability to shift back and forth between the general concepts and specific example. Having the patient identify similarities between like objects or concepts. Like for example, you ask the patient to describe the apple and the orange. What are their similarities? No, like they're all fruit. They are all round. They are all sweet. So these are the examples. The other one is the insight. Insight in the psychiatric evaluation refers to the patient's understanding of how he or she is feeling, presenting, and functioning, as well as potential causes of his or her psychiatric presentation. The patient may have no insight, may have partial or full insight. The component of insight often is reality testing in the case of patient with psychosis. So, like for example, you ask the patient if he or she understands about his or her illness, no? The awareness of his or her illness. So that's the insight. So it's also testing the reality, no? Like in patients who are psychotic patients, no? If there are intact reality testing. So like patients having a good insight is aware that he or she is sick, he needs help, he needs to have consult the doctor and has to take the medication. So that's one of the example of assessing the insight. The other one is the judgment, no? It refers to the person's capacity to make good decisions and act on them. The level of judgment may or not be correlate to the level of the insight. A patient, we have no insight into his or her illness but have a good judgment. So like for example, you ask the patient if you accidentally found a letter with the name, with the address, with the stamp, what are you going to do? It's usually like if you have a good judgment, you need to uh s- you need to go to the post office and mail the letter. Or like if there's a fire, what are you going to do? Of course, first is your safety. So you make yourself safe, and if there is a fire extinguisher, call the fireman or the police who could assist and help stop the fire. Okay? Because some of the patients who have poor judgment, they don't think about their safety, they don't think what to do, like how to stop the fire. Okay. So psychosis is an abnormal condition of the mind, no? It's a loss of contact with reality. These are only the examples, no? Neurosis is a functional mental disorders involving distress, but neither delusions or hallucinations. So there's no delusions, there's no hallucinations. So for psychosis, You have to lose all contact with reality. And there are three dimensions that we discussed earlier. What are those three dimensions for saying that your patient is having psychosis? You have these disturbances in behavior, affect, and cognitions. So these are actually the how you would know that the patient is suffering from any of the psychiatric disorder, no? And the most common one is the psychosis. So if one is having a psychosis, and these are the three dimensions very important that are impaired or disturbed, okay? And you do the mental status, that would also give you the evidence of the signs and symptoms, okay? And aside from that, you will also know it from your history. What are the signs and symptoms? And more in the mental status exam. I think I already discussed all these things in your mental status exams. So you read your textbooks, everything is there. What are the signs and symptoms? And what are mental illness? So when can you say that the patient is having a mental disorder? And if you're thinking about psychosis, there would be impairment or disturbance in all of these three dimensions that are very important. Okay. So that ends the lecture. So the rest of your time, just read it in your textbook. Everything is in your textbook. I think everything is explained, no? So these are the most important things, no, for your okay. And you say about delusions, it's a false belief. Okay. Obsessions, it's more of your thinking. Compulsions, it's more of the motor or the movement. Okay. Obsessive compulsive, it's what you think, you're doing it, right? These are the formal thought disorders. And these are, okay, the perceptual disturbances. Mm, I think that ends the lecture. Thank you.